Yeah.
Hi, everyone. My name is Ashley Howard. I'm Senior Manager for Data and Research at Together for Girls, one of the three organizations that comprise the Safe Futures Hub, along with the Sexual Violence Research Initiative, SVRI, and the We Protect Global Alliance. We are thrilled you're joining us today for the fourth webinar in our solution series on response and support services. We can move to the next slide, please. For those who may be new to the Safe Futures Hub, we are an organization, a collaboration of organizations dedicated to elevating knowledge related to solutions to end sexual violence against children, particularly strengthening systems to end sexual violence against children by disseminating, scaling, and applying solutions that work. And we look to integrate data and evidence with practice-based knowledge and lived experience knowledge. Next slide, please. Today's webinar is, before we begin, please keep your microphones muted throughout the session. Please do use the chat box now to introduce yourself, and at any time during the webinar, share reflections on what you're hearing and your own experiences. Please submit your questions through the Q&A function at any point during the webinar. We'll try to keep an eye on the chat for questions as well, but it'll be easy for us to respond and for each of our panelists to take questions as they come in if you do use the Q&A function. And please note this session is being recorded and resources will be shared afterward. Next slide, please. So today's webinar is focused on response and support services. This, of course, aligns with the sixth INSPIRE strategy from WHO's INSPIRE framework, 7 strategies to end violence against children. The other strategies are implementation and enforcement of laws, norms and values, safe environments, parent and caregiver support, income and economic strengthening, response and support services, and education and life skills. Within today's webinar, Response and Support Services, we're looking to shed light and elevate learnings related to supporting children who experience sexual violence in accessing critical healing support services, such as health and mental health support and integrated victim and survivor services. To put this in a bit of context, according to the Violence Against Children and Youth Survey data from more than 20 countries, only 40 to 60% of children ever tell anyone about an experience of sexual violence. And in most countries, fewer than 10% of children receive services. Additionally, repeat violence against children and youth surveys show important reductions in overall prevalence of sexual violence against children across 4 countries. However, access to quality services is not keeping pace. In countries with repeat VACs, although sexual violence has declined, the proportion of children who experience sexual violence that receive any service has either increased very slightly, as in Kenya, or has actually decreased over time, as in Tanzania. There are likely myriad factors contributing to this, but it is a clear call for action to those of us in the field. Additionally, Together for Girls recently launched the Out of the Shadows Index, which is developed and researched by Economist Enterprise. The index showed a number of critical gaps related to response and support services. Across 60 countries in the index, which represents 83% of the world's children, half of countries have no national guidelines on the clinical identification and response to children who experience sexual violence and forensic evaluation and evidence collection. Only 2 of 60 countries require general medical providers to receive training on identifying and responding to childhood sexual violence. And most countries scored just 25 to 50 out of 100 for access to medical services for children who experience sexual violence. And no country scored 100 out of 100 for either medical services or integrated victim and survivor services. So I'm thrilled that 5 incredible speakers have joined me here today to speak about their experiences related to response services. And I will start the panel discussion talking about what we've learned at Safe Futures Hub so far. Next slide, please. All right, so the Safe Futures Hub builds on the evidence review Together for Girls put out in 2019, which was What Works to Prevent Sexual Violence Against Children. Our first major publication was Building Safe Futures, a 2024 evidence review of what works in low and middle income countries. You'll see me refer to this as the LMIC review throughout this presentation, and we looked at outcomes related to experiences of childhood sexual violence, as well as proxy outcomes like attitudes, knowledge, and behaviors. Another critical output from the Safe Futures Hub has been the role of practice-based knowledge in preventing and responding to childhood sexual violence, which was put out in 2025 and is a background paper elevating practice-based knowledge in the field. And very soon, in the next few weeks, we'll be publishing a high-income country brief, which is an evidence review of solutions in high-income countries researched by Oxford University. Also coming very soon at SBRI, I believe, we'll be launching the first living systematic review dashboard, also developed by Oxford University for solutions to end childhood sexual violence. This will be living in that it will be easily updatable and additive to the field. And then we have a number of case studies, 18 and counting, on our website where we take the evidence from each of these reviews and dive deep to provide a user-friendly, interactive experience for users to better understand how these solutions work and what makes them work for children. Next slide, please. So first, I'll give a little bit of a deep dive into the living, the low and middle income country review. In that review, out of the 72 countries that were included and reviewed, only 3, the smallest number out of the 7 Inspire strategies, only 3 related to response and support services. So I mentioned that again as showing that this is a critical gap in our field. Next slide, please. In high-income countries, by contrast, when we look at just the 80 studies or so that were effective, these are solutions that work. We actually see a decrease in experiences of sexual violence or perpetration for sexual violence. Response services accounts for the second highest of a cluster of solutions after education and life skills for both low and middle income countries. And in our high income country review, most of the interventions that were found were in education settings. In high income countries, 9 were related to response and support services. However, only 1 of those related to actual victimization and responded to children who are at high risk of experiencing sexual violence. The rest were related to prevention of perpetration and prevention of harmful behaviors among children. Next slide, please. This slide just shows a map of where the solutions from low and middle income countries come from. We have quite a range of countries of global majority countries in the low and middle income country evidence brief. The high income country evidence brief is largely clustered in the Americas and the Caribbean, in the United States and Canada, in Europe and in Australia. So what works? In our low and middle income country review, next slide, please, we found no effective intervention types yet, I'll say yet, but we do have one intervention type that we categorized as promising, that is child and adolescent friendly response and support services, and we'll go into more about how that works very shortly. And one that needs more evidence, recognition, screening, reporting, and disclosure of childhood sexual violence. And again, among high-income countries, we found 8 studies that were effective at reducing perpetration among adults and adolescents, and 1 that reduced experiences of sexual exploitation among at-risk youth. Next slide, please. So one example of an intervention type needs more evidence. This is recognition, screening, reporting, and disclosure. An example of this type of intervention is a screening program for sexual violence against children in Kenya. In Kenya, 16% of girls, 6% of boys experience sexual violence, according to the Violence Against Children and Youth Survey. but only 2 in 5 girls and 1 in 3 boys ever tell someone about it. So Pop Council saw these numbers and realized that it is critical to start identifying children and linking them to healing services. They did a formative evaluation and found that 96% of children and 61% of parents were willing to participate. 75% of children who disclosed obtained care due to the intervention. We don't yet have information about how the services helped those children, which is why this needs more evidence. But it's a really interesting intervention and deserves more attention and more research. Next slide, please. And then in terms of our promising intervention type, child and adolescent friendly response and support services, their IRC employed a mobile approach for delivering services to Syrian refugees in Lebanon and found that that mobile delivery approach worked in terms of getting healing services to children, both logistically and in helping them in their healing journey. Next, please. We also have a number of important learnings from our practice-based knowledge paper showing that lived expertise is critical, ensuring that child sexual violence responses are grounded in the lived realities of those most effective, and then critical practitioner expertise and adaptations that have to be made based on particular situations, such as boys in conflict and detention in Palestine, and healing historical harm in Indigenous communities in Alaska, for example. All right, that brings me to the end of my presentation. So I am delighted to introduce Dr. Sarah Meyer, scientist with the World Health Organization, who will share with us more about approaches to medical and integrated services for children who experience sexual violence. Over to you, Sarah.
Thanks so much. Yeah, thank you so much for having me. I'm really happy to be here and be able to reflect a little bit on the role of the World Health Organization in response and support services. So next slide. But just to situate our work, the WHO has an institutional mandate, which is really developed on working on violence against children. So that comes from various resolutions, one of them in 2016 on strengthening the health system response to violence on women, girls, and children. And consequently to that, a global plan of action of recommended actions for member states to take. Alongside these other resolutions, it's really been that WHO has worked to establish this as a public health issue and something that should be addressed alongside other child and adolescent health priorities. And so, for example, in this regional implementation framework for newborn child and adolescent health, violence against children and injuries was identified as key areas of work alongside the more sort of bread and butter work of addressing child and adolescent health that has been the mainstay of the WHO for many decades. Next slide, please. So based on those resolutions and based on those priorities, there are various documents, guidelines that we have come out with. The 2017 guidelines have specifically the objectives of supporting healthcare professionals to provide quality, immediate and long-term clinical care. So this is really focused on clinical response. But also that in providing that clinical response, that can be and should be applied in an ethical, human rights-based and trauma-informed approach. Next slide. Those guidelines have really been operationalized into this clinical handbook, which has practical guidance for healthcare professionals and different cadres to recognize signs and symptoms of violence against children, including sexual violence, to provide clinical care, including psychosocial support. And then on this last point, because we see the health sector response as embedded within a broader multi-sectoral approach, that is also has recommendations around liaising with other support services within and outside the health system. Next slide, please. So really a question, or, maybe no one on the call has this question, but a question can be, why is there such a emphasis on the health sector? What is it that health professionals can really do? And we do find that in many contexts, healthcare professionals see this as outside of their scope of work, or something that they're nervous or don't have enough adequate training to work on. But what we know is that healthcare professionals have a very unique position in which to identify and support child survivors of violence. So unfortunately, with how high prevalence is in all countries, a large proportion of the children that they will be seeing for regular checks, from vaccination through to adolescent sexual and reproductive health services, will have experienced maltreatment, including sexual violence. So healthcare professionals are often the first point of call. Children could be attending health services specifically due to injuries or mental health impacts of violence, or be attending, a regular health visit or on a different health issue, but that still gives the opportunity for the healthcare provider to be able to identify and provide support. And another life stage where healthcare professionals are more regularly seeing adolescent girls around sexual and reproductive health issues, and that also provides opportunities to identify and support. Next slide, please. So the question is, what is it that healthcare providers can do, and where does that also fit within the prevention continuum? And most of what we're talking about here is not primary prevention, but rather secondary and tertiary prevention. So where children have already gone through sexual violence but can be prevented from further exposures, the harms can be mitigated, and they can be provided with services that will support them in different choices that they would want to make. So some of those roles of the healthcare provider include recognizing signs and symptoms. So that can be where there's often a mismatch between how a caregiver might be explaining how injuries were obtained, or why there's a chronic issue with a child, and what the healthcare provider might identify as a pattern that may indicate violence. Providing first-line support, which I'll go into, and liaising with other services. So on to the next slide, and I want to give a little bit more time to these next two. So the first is on providing first-line support. So we have an acronym, it's LIVES CC. So the LIVES acronym was also included in the clinical and policy guidelines specifically on violence against women. But that's around that a healthcare provider should, as a first-line support, be able to listen closely, inquire about women's needs, validate experiences, enhance safety, including, if appropriate, developing a safety plan, and again, referrals and connections with additional services. In addition to the lives, for children, it's important to have the CC, which is the child and adolescent friendly environment, and caregiver support. So just to the next slide, and I'll finish there, is that in the case of sexual assault that has included sexual intercourse, there are several additional steps that healthcare providers are recommended to take in our guidelines. So starting with the listen, inquire, validate, but then, and there are very detailed guidelines and information on this around how to take a history and conduct the examination in a context where HIV may be prevalent or potential, is provision of post-exposure prophylaxis, prevention of sexually transmitted infections, and in some contexts where emergency contraception might be needed. So I did have a slide that looked a little bit, we can go, and I'll just leave it as a visual for a minute as I wind up, but the ways in which this has been integrated and used in country context has been very varied. As Ashley said, there's very wide variation and huge gaps between what is in national guidelines and what is actually implemented. One good example that we have seen is in Namibia, and there's a whole process that has involved legal reforms, data generation, national action plan, and on this last point in 2023, using these clinical guidelines and this handbook for health professionals to do really a cascaded training across different cadres of health and social sector workers to ensure that they are able to provide this first line support, the live CC, and also where needed, that those steps on clinical care for sexual abuse are integrated. So I will finish there and looking forward to the next speakers, and thanks very much for having me. Thanks.
Thank you so much, Sarah. It's incredibly helpful to set the stage with international guidance and best practices for responding to children who experience sexual violence with a focus on the medical field. Now, I'm pleased to introduce our practitioner speaker panel. We'll hear from Martha Sanda from Childline Kenya, Sandra Vasquez, Executive Director, and Maria Contreras, Head of Projects and Research at FUSA. And then we'll hear from Joanna Marano, Network Coordinator for Sports Rights Alliance. And each of our speakers will share their related experience to response systems and supporting survivors and share lessons learned for navigating the complexities of implementation to build more effective, accessible, and child-centered responses to childhood sexual violence. Martha Sunda, welcome you to the floor.
Thank you. Thank you. I have 6 minutes. I'll see how much I'm able to cover within that period. I think the best place to start here is to give a background so that we understand when we are talking about response in our setting, how does that look like? So we run the National Child Helpline Service in Kenya with the State Department for Children's Services, which is a government entity. So we co-manage the Child Helpline Service, which is available on a very short code, 116. And when we receive these concerns reported, we then create a case plan for the client and figure out what the need is, what services might be required, who will provide those services. And then we walk that journey with the client to make sure then that they receive the assistance they require, all right, but also that it is comprehensive, it is timely, and it is of good quality. That is not easy to do, but thankfully we have the support of the government counterparts, and we have other civil society organizations and individuals as well who provide these services. So that's the background of how we do our work, largely. For us, what child-centered response looks like is that then the children and their families or the community is able to access a safe reporting platform. And that is why we have the Child Helpline. And apart from the telephone service, we are also available on written media, let me call it that, which includes social media and email, but people can also just walk into our centers and talk to a professional counselor or a children officer for assistance. And this is important because then the child has the choice to make if they're able to make a call, if they prefer to chat, if they'd rather walk in, there's that option for them to do just that. And it gives them the peace and safety even as they seek help. The second thing is that we need to then have effective and efficient response, because sometimes that is the only opportunity we have. That one call is the only opportunity we have to really respond to that child. And so it is important for us to then always have our database of service providers from all over the country to know who is nearest the child at that point, who is able to serve them. Thankfully, we have access to all these children officers spread out all over the country, and they are therefore able to provide that service, or at least know who is doing what, where, nearest to that child, and they're able to coordinate that service for the child. Comprehensive case management is also critical so that you know by the time you're talking to this child, there's the beginning up to the end of this issue so that it is resolved. So we need to also be alive to the fact that there are several steps that will be required, different people involved, including the child themselves, who is the client in this case, so that the case management is not like medication in doses, but there are different people playing different roles and ensuring then that even the positive change or response is sustainable beyond the immediate actions that will be taken. So there's that continuous engagement and follow-up. Coordination of the multi-stakeholder or multi-sector response is critical, and thankfully for Kenya, with the State Department for Children's Services, the children officers are required to coordinate that kind of response for the child. And so when we refer these cases to them, we can hold them accountable to ensure that every piece of the puzzle works together in the best interest of this child. And they're able to report back when we have the case conferences regularly, and they're able to say, this is how far the case has gone. This is where there are gaps. This is where we need help. So that is critical. And the children officers are able to do that continually as well. And then beyond the immediate need that the child has presented, or the family or the adult has presented on behalf of the child, there is need then to check beyond the immediate resolution. Progressively, has that been sustained, or are there other issues that need to be dealt with so that the child is not re-traumatized or finds themselves again violated or exploited? And so our guiding standards, I will not even go into the details of this as I have been speaking about them as I explained our work. But for us, the best interest of the child comes first, as it should be for us as practitioners working with children. Their active participation also, so they're not just there following and but agreeing to everything that is being said, but they need to also have their feedback taken into account. They need to know, why are we moving this way? What do we expect? What am I required to do as a child? So that they are active participants rather than just observers and people who follow the instructions. Their dignity and privacy, that we can never overemphasize in these discussions, so that even as we engage with the different players, the children are held and supported with dignity, and their privacy is upheld all the time. Age-appropriate care, of course, that is also required, because there's also the capacity of the child to understand processes, to integrate with their day-to-day lives, their changes that might be expected after such trauma as well. So just walking with them that journey and providing information in an age-appropriate manner or level as well. And so also I spoke about how the children officers coordinate service, and that is important so that it's not fragmented and not everybody's running everywhere. And there are things that also then fall through the cracks. Next slide, please. Okay, so what has been most effective for us? I will summarize that as well. One of them is just the aspect and opportunity for people to reach out to us through the different available channels, and also the fact that they can reach out anonymously. The requirement, therefore, even when you're reaching out anonymously, is that you provide as much information as possible so that we do not have to come back to you even as we respond to the child, if that information is comprehensive enough. But there's opportunity to do that anonymously. And then also you can do that at the comfort of your home. You don't have to come all the way where we are. Our strong partnerships, especially with the government entities who have the biggest mandate for child protection, I think that's a big win for us and has been very effective. And then also having them coordinate the service for the children so that they are reporting back, we can hold them accountable. They can reach out for other support, financial, human resource, things like that, but entirely they are in charge of the process. And that I think is very critical. And then the rest of us partners can support and provide the other services where the gaps exist. Trauma-informed care is relevant, especially when we are looking at the best interest of a child and what it means for each of the children differently. There's no one size fits all kind of response here. So it is guided by what the child has gone through and how they're responding as well. So mental health is child protection. So when we look at child protection over time, it has looked as if when we are done with the legal processes, then yay, we have won. But beyond that, there's other support for this child to bounce back and thrive in their childhood, and also the network around them, including the family, the other children, the community around them. So when we are looking at child protection, it goes beyond the legal support. It also covers largely the mental health for this client and also the network that surrounds them. And continuous follow-up then cannot be overstated, really, because at every point there are opportunities for us to check whether the positive feedback, the positive outcomes are sustainable, or there are things that still need to be done so that the child really enjoys their childhood. Next slide, please. All right. So as I was speaking, someone might think it has been all rosy the whole time. Certainly not. It's very difficult to support children in this way and still ensure that it is effective and it is efficient as well. So some of the challenges, and one of the biggest challenges, I think, globally is the issue of limited resources. You want to do so much, but what is available to you might not be as much. And so you find that sometimes you're slowed down in terms of responding to that child, not because you do not want to, but because you're limited in terms of what is available for you. So that's a big challenge. Another one is underreporting, and that is born out of many times the beliefs, the cultures also of the people who are in.
Are others hearing Martha? Martha, I think we've lost you. Okay. Martha, we can come back for your final reflections at the end of the panel if we have a few moments, which I think we'll be able to squeeze. I'll go ahead and thank you, Martha, for these incredible insights and reflections on your work, and pass it over to Sandra and Maria from FUSA.
Hi, everyone. Thanks a lot. My name is Maria Eugenia Contreras. I'm the head of projects and research at FUSA, a civil society organization from Argentina working in the intersection of health and human rights. I am joined today by Sandra Vasquez, the executive director. Our work is deeply rooted in the public health system. Together, we have more than 35 years of experience working in public hospitals and participating in national advisory councils, scientific societies, and health coalitions. This experience, together with our participation in Argentina's National Roundtable on Child Sexual Abuse, allowed us to understand the absence of a comprehensive response for children and adolescents surviving chronic intrafamilial sexual abuse. So before we began this work at FUSA, there was no comprehensive response within the health sector to this kind of abuse, because health services only have protocols for responding to acute cases. Also, existing responses were fragmented and poorly coordinated between health and justice. Healthcare professionals lacked specialized training, interdisciplinary approaches, and evidence-based diagnostic models that could support children while also facilitating access to justice. Children were often unable to obtain a reliable diagnosis within the healthcare system, while the justice system frequently failed to establish the facts necessary to hold perpetrators accountable. But without truth, there can be neither justice nor genuine healing. The consequence is devastating. Widespread immunity, children denied justice, and in many cases, children who are even forced to reestablish contact with their abusers. Another critical gap was that interventions rarely considered the role of protective mothers. They were expected to navigate an overwhelming health and justice system entirely on their own, while simultaneously supporting a traumatized child and often facing intimidation, disbelief, and legal attacks themselves. So what we did is we developed a model of care combining the best available scientific evidence with the best practices we had identified throughout decades of public health work. We learned from professionals across Argentina who had spent years responding to child sexual abuse without formal protocols or institutional guidance, relying only on their expertise, ethical commitment, determination, and conviction to protect children. We brought together these dispersed practices, created an advisory board on child sexual abuse composed of experts, and transformed this collective knowledge into a clear, structured, evidence-based model that could be replicated. Throughout our experience, we realized that although international guidelines clearly describe the healthcare sector's role in detecting child sexual abuse, we found very little guidance on how to diagnose chronic intrafamilial abuse, particularly when there are no physical findings because the abuse occurred months or years earlier. Our model is centered on, first, the survivor protective mother diet. It combines specialized healthcare, social legal guidance, and an evidence-based diagnostic tool that produces comprehensive biopsychosocial assessment reports and tries to bridge the clinical language of healthcare and the language required by the justice system. The model is implemented by an interdisciplinary team. Through a series of structured interviews, children and adolescents are given a safe, trauma-informed space where they are listened to, believed, and treated with respect. In parallel, our social legal guidance helps protective mothers understand the justice system, organize the many decisions they need to make, and navigate the critical pathway that begins once a report is filed. For many mothers, simply having someone explain what comes next and help organize the process is in itself therapeutic. Our intervention helps restore order in the midst of the overwhelming emotional chaos created by a child's traumatic experience. It also equips families to respond to harmful legal constructs which continue to be used to undermine survivors and protective mothers. Our approach is grounded in the understanding that access to justice is an essential component of health and recovery. So for us, the first signs of change emerged when we were able to provide children and adolescents with a safe space. For many survivors, being listened to, believed, supported, and having a healthcare team validate their experiences marked the beginning of healing. For the first time, someone acknowledged that what happened to them was real. Our conviction has always been simple. We believe survivors. But belief alone is not enough. Survivors deserve to be accompanied with scientific rigor, professional expertise, and evidence-based practice. The knowledge exists. The evidence exists. Our responsibility is to apply it. Ultimately, we believe that diagnosis can transform the response to child sexual abuse. This is one of the most important lessons we have learned. Diagnosis is not simply the end of a clinical assessment. It changes outcomes because it helps reduce impunity by producing high-quality clinical evidence. Because it protects professionals and families from backlash by replacing individual opinion with collective, evidence-based, interdisciplinary knowledge. And it changes outcomes because it marks the beginning of healing by validating children's experiences and restoring their rights. Thank you very much.
Thank you so much, Maria and Sandra. We'd love to welcome Joanna from Sports Rights Network.
Thank you very much. It's really a pleasure to be here. I hope you guys don't mind where I'm sitting. This is my mom's duty. As soon as the webinar is over, I need to go pick him up. I was wondering if I should have some slides or just use a couple of minutes to have a conversation with you, and I've chosen the latter. And I'm going to explain why. I am someone who fell in love with sport at very early age. Like my first memories of swimming, I'm a former professional swimmer, come from this feeling of belonging and then having this certainty that I was at the right place, at the right space. Just sport just felt right for me. And so I had a lot of dreams in that space to go to the Olympic Games, which I did four times. So I was able to build the best version of myself in that space. But also because I was so driven by that goal of making to the Olympic Games and winning. This was also the space where I was groomed and severely sexually abused. And I'm saying this not because this conversation is about me, but because my story is very similar to what many children face in the context of sport. This is extremely common within the sport sector. Today, I work at the Sport and Rights Alliance, and we are this global coalition who fights for human rights in and through sports. Basically, we do believe that sport can be an authentic force for good. However, we need to make sure that we protect the rights of children, the rights of fans, the rights of journalists, the rights of survivors, the rights of migrant workers. So everyone who is somehow within the scope of sport. And what I think is important to say is that sport is a quite a particular sector when it comes to responses and how they protect or do not protect the most vulnerable, in this case, children. And that's because sport benefits from a lot of autonomy to regulate itself. Due to the very specific disciplines, for instance, swimming, the rules of swimming are very different from rules of judo. They're very different from the rules of football that we're seeing now with the World Cup. So because of those specific rules, specific organizations were created to regulate those different sports. And there's also the fact that sport is overall perceived as very positive from a society. And to some extent, that is actually true. Sport can improve our health. Sport can help us with social skills and so many good things. But at the same time, this positive perception, this broader positive perception, makes it really hard to hold sports governing bodies accountable and even gain society support on our efforts to make this space safer for children. And on top of all of that, there's also the challenge that comes from the win at all costs mentality and the competitiveness that we don't want to reject, right? We think that competitive is important. Like if you go to a playground with kids as young as 2 years old, they will be seeing who climbs higher, who runs faster. So competition is not bad per se, but the misuse of it is what exploits children and dehumanize individuals. So the big challenge here is how do we make people understand that any individual in sport, including children, they are human beings first and an athlete second, right? And how do we solve this equation to make sure that people understand that safety and a child-centered sport sector, they're not at odds with performance. There is no scientific evidence that a coaching style that is that use coercion and verbal abuse or psychological abuse, physical abuse, or even sexual abuse makes people perform better, makes children better at sport. There's absolutely no evidence to that. That doesn't stand. So how do we try to solve this equation within a sector that is perceived by society to be extremely positive, while at the same time recognizing that it can actually be positive? So when it comes to the response pillar at the Sport and Rights Alliance, we try to prioritize victims and survivors of abuse in sport. And we do this through different avenues. The first one is the provision of services. So we created an emergency fund that is aimed at providing financial support so that people can continue their healing journey. So whether they need psychological support, legal assistance, or any other essential services to move on, right? And this was created by and is governed by an advisory council that is composed by survivors of abuse. And while we did that, it's really with a purpose. That is to show that by example, that it is not just possible to center survivors in decision-making process, but also if a very small NGO is able to set up a fund, the big sports governing bodies, IOC, FIFA, UEFA, and many others are able to do that as well. We also act as spokesperson within sports governing bodies because it's extremely hard and it can be very dangerous to stand up against those big, powerful institutions by themselves. So we do try to speak on behalf of impacted people and children whenever sports fail to act appropriately to protect children. And then thinking more strategically than like prevention in the long term, but also the response, we advocate strongly to make sure that the big sports governing bodies, here we're talking about International Olympic Committee, we're talking about FIFA, we're talking about UEFA, to adopt strong, binding, safeguarding policies that they're able to hold them accountable, but also to hold the organizations that are under their umbrella accountable. This is particularly important because it will help to decrease that level of autonomy that I mentioned that they have. So in a nutshell, that's what we do. So we provide services. We show that it's possible to center survivors when creating those services. And we keep advocating to make sure that we have more teeth to make sure that sports not just choosing how and when they're going to respond when those cases happen. Thank you very much.
Thank you so much, Joanna. All right, we have reached the question and answer part of our webinar. If anyone does have a question, I think we're able to take live questions. So please do feel free to raise your hand and or type or just come off mute or type your question in the chat or in the Q&A box, and we'll be happy to answer. And then let's see, Martha, did you want to give any final remarks? I know you were cut off just a little bit short. Give you a chance, Martha, if you want to come in and wrap up what you were saying, if there was anything final.
Yeah, sorry about that. Internet happens on you sometimes. I think what had remained were the recommendations. I was speaking through some of the challenges. Yeah, maybe I could take a minute and finalize that. Thank you, Arunima, for putting that up. All right. So we were talking about how we respond to children and whether there are any challenges. We have already covered the first two, the resources and also attitudes and culture. There was the issue of fragmented response, let me put it that way, in terms of the different agencies providing different services. And that also means that my agency does not necessarily push the other party to take it as urgently as I would like. And so, yeah, I might be stuck in terms of the progress with that case. Referrals have that challenge, but thankfully everybody has their own strength, which we maximize on for the benefit of the survivor of sexual exploitation. And then now we have online risks, which present differently and sometimes are very difficult also to go through court with successfully. They can be questioned because of possibilities of manipulation. So that makes it a little difficult. But governments are progressively addressing this and ensuring that that is covered within their laws so that we are able to respond to survivors of the same. So some of the recommendations for us, and knowing that we can never do this comprehensively on our own, we need the help of the government at all levels in Kenya so that there are systems in place, structures in place to make sure that the child can access the service or right, but also go through the system without being re-traumatized and be able to truly thrive and not be exposed further to more harm sexually and otherwise. And for the donors or funders or development partners, then we also need to see how to fill the gaps where the government has not been able to do very much so that we are strengthening that which is sustainable rather than fragmented support of different interventions that not necessarily feed into the larger systemic change. So I think we need to look at how to be very strategic about resourcing, but also supporting as CSOs. Where are the gaps? How do we deal with duplication of efforts as well? And also with the child protection organizations, it is important that we see beyond meeting targets and ticking check boxes so that we are truly responding to that child or the survivor of sexual exploitation. And we move at their pace depending on what their needs are and what services they truly require beyond what we have signed for with our donor, perhaps, which can be limiting sometimes. And so for us, really, I think the parting shot would be that every child deserves protection, justice, healing, and hope. And that is comprehensive so that we're able to truly assist them. Thank you very much for that opportunity. I think I'm done now. Over to you, Ashley.
Thank you so much, Martha. I'm glad we had a chance to hear the rest because that was really enlightening. So I'll just go ahead and provide a bit of a wrap-up summary, and I'll invite all of the panelists to weigh in if you'd like to say any final words as we close once I finish as well. And we do still have time for questions if anyone has them. I don't see any at the moment. So I think in this webinar, we've heard that in almost all settings, there are critical gaps in response and support services for children. We've heard about the importance of international guidelines and underpinning all of our response efforts, particularly the basic package of care in terms of providing medical and health, as well as integrated support services for children who experience sexual violence. I heard across speakers today the importance of adapting response services to different contexts, whether that's at the country level or children-specific environments such as sports, even different sports. something that really rang true for me today that I heard loud and clear is that across the board, one size does not fit all. Children and survivors need responses that are tailored to their individual, very individual experience, their needs, and what they want to get out of their response services and their healing journey. I think everyone mentioned the need for coordination, the importance of guiding children through these incredibly complex systems and simplifying their experience and navigating that so that the first place they come and they tell their story to, they don't have to continue to tell their story over and over again. And then the importance of recognizing the role of parents and caregivers and families in supporting children and supporting the importance of supporting those families and caregivers as they navigate complex systems and support traumatized children. Would any other speakers like to give any reflections? If not, please do let's see, where is the poll actually? We have a poll, a feedback poll that we're going to share with you momentarily. It's popping up right now. So please do share your feedback about this webinar and be on the lookout for our next webinar, which will be announced soon and we will hold in September. Thank you so much to Joanna, Martha, Sandra, and Sarah for being with us today. We so appreciate your insights and I think everyone has really gained from your experience. So thank you.
Thank you so much. Bye-bye.
Thank you so much.
Thank you very, very much.